Thank you so much. I am going to be talking on optimizing toric IOL outcomes, just a few tips which are relevant. One of the basic things is do not give any weightage to the refractive astigmatism simply because lenticular astigmatism might completely gives you a false impression about the astigmatism that you need to deal with. You don't really need an eye trace to go ahead and implant toric intraocular lenses, but just to drive home the point that I made just now, here is a case where you see that there is a significant amount. This is total corneal astigmatism. This is the internal optics, which is the lenticular astigmatism. This is from the cornea. If you see, this patient was wearing glasses, astigmatic glasses right through his life, and almost the entire astigmatism is um, uh, from the internal optics, from the lens, which is not quite rare. Once this lens comes out, obviously the cornea itself is pristine. So obviously, even though the patient was having astigmatic power in his glasses right through, he is not a candidate for a toric intraocular lens. Contrasted that with this case where the internal optics and the corneal anterior corneal astigmatism tends to cancel out each other, so that right through the life of the patient he or she has not been wearing an astigmatic correction in their glasses. But once the cataract comes out, this anterior corneal astigmatism is going to become manifest, and obviously this patient would qualify for a toric intraocular lens. It's extremely important that you use the right instrument and the right formula. There are several different formula that we have nowadays in our armamentarium. We usually go with the Barrett toric calculator. Actually, when we put the patient on any of our optical biometers, it is not the it is the go-to formula is not Barrett Universal 2 or the Barrett toric calculator. That tells us whether the patient is fit for a toric monofocal, toric multifocal, and then the entire counseling for the patient is done accordingly. This is simply because we came across several situations where the patient had been found to have minimal cylinder, talk to about multifocal intraocular lenses, but when we do the biometry, we find that the patient requires a toric intraocular lens. So we had to re-counsel the patient about the need for a toricity. So the Barrett toric calculator is our go-to formula. Based upon the outcomes of that, the entire counseling is warranted. Where exactly you get this Barrett Suter formula? There are several different biometers that is available with with these formula incorporated. But the most importantly, even if you don't have access to an optical biometer, you can go ahead into the ASCRS or the APACRS websites, and you have all these formula accessible to you. You can get your biometry done with the immersion A scan. You can do a manual keratometer, but then you can have the benefits of this modern formula to exactly calculate the IOL power that has to go in. Correct even low astigmatism with multifocals is extremely important, and as you can see over here, this was a patient who underwent a trifocal intraocular lens implant, seemed to have a less than a diopter of corneal astigmatism against the rule. We went ahead and implanted, this was about 4 years back, implanted a trifocal panoptics lens, and what the patient ended up was an excellent near visual acuity of N6, but had a significant mixed astigmatism, because of which the patient is unhappy, and you can see that he had an uncorrected visual acuity of 6/12. These situations we do laser touch-up 3 months after the primary surgery. That's what the patient was counseled for. He was an understanding patient, and he said that while waiting he'll undergo the second eye surgery. Almost a similar amount of astigmatism, but when we used a toric calculator, what we found was that the patient needed a T3 toric intraocular lens, again a T3 trifocal toric, and you see the outcome immediately. The second eye, which received a toric intraocular lens, has an excellent uncorrected visual acuity of 6/6. So after a couple of months, the patient had to undergo a cylindrical correction on the cornea. Obviously, that's the reason that even for small amounts of astigmatism, we go ahead and use the toric intraocular lenses in multifocals especially. You again have to understand that I'm often asked, what's the power beyond which you recommend toric intraocular lenses? It's not just the number alone that is important, it's also the axis that is important, because the posterior corneal astigmatism increases the amount of astigmatism that the patient has to deal with, while the anterior corneal astigmatism to some extent gets neutralized by the posterior corneal astigmatism. Look at this patient who has a 0.9, less than a 1 diopter of astigmatism, but it is against the rule astigmatism, and the calculator shows that the patient requires a T4 cylindrical correction. So obviously a candidate for a toric intraocular lens. On the other hand, a patient with the rule astigmatism almost of a similar diopter, what the formula shows is non-toric. So it's not just the number of the cylinder that or the corneal astigmatism that's important. The axis is also extremely important in deciding whether you want to go for a toric or not. For us, extremely important that you understand the concept of surgically induced astigmatism. For a long time, I used to think that my temporal clear corneal incision, which is of 2.4 millimeters, creates an astigmatism of 0.44 diopters. But now we understand that the SIA just doesn't have a magnitude alone, but it has an axis also. And because of this, when you calculate the centroid value for a sub 2.4 millimeter incision is just about 0.1 diopter. So the concept of calculating SIA has gone, especially if you have making incisions of about 2.4 millimeters. So you can either ignore it or just give a value of 0.1 diopter in these situations. And repeatable axis marking pre and intraoperative is extremely important. Depending on whatever you are familiar with, you can use any of these modalities. If you have a digital marking system, that's of great use as far as getting excellent positioning of these lenses are concerned. But if you have a good experience with any of these systems, that will also work well. I personally, I most often use a digital marking device on the operating microscope. But before that, I used to go with the slit lamp, where with the undilated pupil, we used to mark the 0-180 degrees axis, and then subsequently do a marking onto the during the surgery. An intraoperative alignment is extremely important. A very short video, and what you see over here. These are the days when I used to use a viscoelastic for introduction of the intraocular lens, and it's extremely important that these intraocular lenses are positioned rightly, and then subsequently the viscoelastic is completely removed both in front and behind the intraocular lenses. It's well shown that 87% of the rotation of the intraocular lenses occurs within the first 1 hour of the intraocular lens implantation. That's often because of the residual viscoelastic that's left behind, which acts as a cushion for the lens to rotate. That's the reason that you don't want to overfill these bags also, because that also creates a propensity for the lens to rotate. And that's the positioning of the lens. And nowadays what I do is this hydroimplantation, where basically once the lens is the nucleus has been taken out, we just have the irrigation cannula in place, and you can see this. I specifically chose this video because you can see the lens appears to be a little uncontrolled, but even in these cases you can manage them quite well, position them accurately, and then with just the irrigation flowing, you can position these lenses very well. So that does away with the variability of having to remove the viscoelastic completely, and usually what you find is the way you left the lens is the way it remains post-operatively. Residual astigmatism, if you have, we use the Barrett RX formula that tells us, for example, if you have a residual astigmatism like this, +1 with -2.5 diopters of cylinder. One thing, rotation of these lenses is going to help only if the total amount of residual astigmatism, the spherical equivalent is almost 0. That is, this and this tend to cancel out each other. In these cases, you can go ahead and do a rotation of this lens. That's again a fairly simple procedure. You can also do a piggyback intraocular lens, or you can go ahead and do a laser vision correction. So the final take-home tips are multiple measurements of K reading. Consider but do not be guided by the refraction cylinder. Check the ocular surface even before you take the measurement. The surgically induced astigmatism is 0.1. The posterior corneal astigmatism is to be considered by the formula. You make a little longer incision. Avoid overinflating. These are the surgical tips. Ensure complete visco removal. Nudge the intraocular lens onto the PC. And make a slightly smaller axis, as I just emphasized, so that the lens is well encaptured in the capsular bag. ensure that even after the speculum is off, the lens remains in position. And if there is a residual astigmatism, go ahead and rotate the nucleus, rotate the intraocular lens 2 weeks after the primary surgery. Thank you so much for your